Thank you. Okay, there's a little problem with the tape, so we're just going to start with the knee joint all over again. So some of this is going to be repetition. Sorry about that, but these things happen, right? Okay, so knee joint. Once again, we're going to look at the knee joint. Okay, I want to tell you all the different structures of the knee joint because there are multiple structures and they're all very important, and some of them are prone to very specific injuries. First things first, the bones that are going to create the knee joint. There's the femur. The femur on the end is going to have two rounded condyles. Those condyles are rounded portions that'll sit into the top of the tibia. The tibia has what's called a tibial plateau, which is just two small indentations into which the condyles of the femur sit. The fibula does not really contribute to the knee joint except for one ligament. The fibula, keep in mind, is on the lateral aspect of the shin. Okay, so femur sitting on tibia, fibula is going to be on the lateral aspect of the shin. Okay, on the ends of the condyles of the femur, we will once again have articular cartilage. That articular cartilage will provide that cushioning for the knee joint as it sits into the tibia. Okay, now let's look at the different parts. I'm going to start at the top and make my way down. I know this is a very confusing picture, so I'll walk you through it. Once again, if you can't see this picture on the PowerPoint here, get your book open. It's the same exact picture that's in your book. Okay, so joints between the femur and the patella and between the femur and the tibia. Okay, so the patella is going to be the knee bone. What happens, and you can see the patella is cut away in this view, okay, that little kneecap portion of the knee. The patella is connected down to the tibia by what's called the patellar ligament, okay? So the quad muscles will come down, insert onto the patella, and then you'll have a ligament from the patella down to the tibia, okay? The reason that that's important is because you could get wear and tear on the back of the kneecap. That wear and tear can actually cause little bits and pieces to break off and go into the joint. The other thing that the patella can do is it can actually track to the side instead of living right in the center of the knee joint. If it pulls off to this side, it can create all sorts of imbalances in the knee and it can cause some wear and tear in the knee, okay? So the patella. The next thing that we're going to talk about are the menisci, okay? The menisci are C-shaped cartilaginous structures that'll sit right on the tibial plateau. There's one here and there's one here. Their job, once again, is to provide a cushion for the knee joint so that we don't have the femur articulating or touching directly onto the tibia, because that would be bone on bone. That would be very uncomfortable, okay? There's a lateral meniscus. The lateral meniscus is towards the fibula. There's a medial meniscus, which is towards the inside of the knee. Okay, both of those C-shaped cartilaginous structures can get injured. We can get little rips and tears in them that can flip up and into the joint, can cause a lot of discomfort, clicking, popping, and swelling. Okay, torn menisci probably sounds familiar. Patellar ligament we just talked about. It's going to connect the patella to the tibia. Okay, fibular and tibial collateral ligaments. The fibular collateral ligament is right here. The tibial collateral ligament is right here. Fibular collateral ligament is also known as lateral collateral ligament because it's on the lateral aspect of the knee. Tibial collateral ligament is also known as medial collateral ligament because it's on the medial aspect of the knee. Okay? These can get injured with a shearing force that goes across the knee and it can pop those ligaments open. Kind of painful. Okay? Medial and lateral collateral ligaments, also known as tibial and fibular collateral ligaments. Okay? Finally, this probably sounds familiar. Okay? ACL and PCL. Anterior cruciate ligament, posterior cruciate ligament. Looking at the picture, anterior cruciate ligament is here, posterior is here and is towards the back. What those do is they help to check the sliding of the femur on the tibia. Anterior cruciate prevents the femur from sliding forward. posterior cruciate prevents it from sliding back. If you have somebody who's running very fast on a turf field or on a regular field and they stop and the femur keeps sliding forward on the tibia, they can rip that anterior cruciate ligament, an ACL tear. Okay, so those are very important for us to know to check the sliding of the femur on the tibia. Okay. Shoulder joint, okay, has a lot of movement. With more movement, we're going to have less stability, okay? But we need that less stability because if we had a lot of ligaments supporting this joint, we wouldn't be able to move our arms in all the ranges of motion that we need to move in order to survive and to go about our daily business. They're supported by ligaments in the shoulder, but the primary support is going to be the rotator cuff, also known as the sits muscles, which I will talk to you about next week when we talk about muscles, and the bicipital muscle. Okay, biceps crosses the shoulder joint. It helps to hold the shoulder joint into place. There's a little cuff of cartilage that helps to support the joint as well, but primarily it's going to be ligaments in the rotator cuff holding the shoulder joint in place. The shoulder joint, just one other thing about the shoulder joint, is only connected to the bony skeleton at the sternum. Okay, if you think about it, the clavicle connects to the sternum. The clavicle comes out, touches against the acromion of the scapula. The scapula just floats on the back. So the only bony attachment of the shoulder girdle is going to be right at the sternum. So it's really kind of an unstable joint. The only thing that gives it stability is the ligaments and the muscles, the rotator cuff. Okay, hip joint. The hip joint is going to be more stable than the shoulder joint. There's still a fair amount of movement in the hip joint, okay? But it's going to be less movement than the shoulder joint because the primary purpose of the hip joints is to give us mobility and move us through space, okay? The ball and socket structure of the hip joint is going to be much deeper than the ball and socket of the shoulder. That's one of the primary things that creates more stability. You're also going to have slightly bigger ligaments to support that joint. You could cross over. I'm actually going to zoom in so you can see it a little bit better. Okay, ball and socket like the shoulder, it's deeper. It's supported by more ligaments. It's also supported by much stronger muscles. Okay, and those muscles are meant to move us through space, to move our whole body weight through space, as opposed to the muscles of the shoulder, which are meant to give us the fine movements to help us to manipulate our environment. Elbow joint. The primary motion of the elbow joint is flexion and extension. There is an articular capsule and supporting ligaments. Okay, we're not going to get into those specifics, but I do want you to look behind what's called the olecranon, or the point of the elbow. If you can't see this, please make sure you open up your book. There is a bursa. That bursa can get severely inflamed and enlarged and cause a lot of discomfort in people. Okay, so if somebody has an injury, a bump, overuse, some sort of aggravation to that area, that bursa behind the olecranon can get inflamed and enlarged. Okay, common joint injuries. A sprain is an injury to a ligament. Okay, there are different grades of sprains. There can be a simple stretch to that ligament, which is going to be a very mild sprain, or the ligament can be torn completely, which of course obviously would be a severe sprain. They heal very slowly. Now, if a ligament is torn, it's not going to heal. It needs to be surgically fixed. But if it's overstretched, it takes a long time for it to heal. And can you guess why? Because there is little to no blood supply. All the blood supply that gets to our ligaments or tendons is just through passive diffusion. It doesn't have a direct blood supply. Okay, cartilaginous injuries. I want to back up actually. I want you to add onto this slide a strain, S-T-R-A-I-N, a strain. What a strain is injury to a muscular tendon, okay? Connected to muscles, we have tendons. So if we stretch or tear the tendon that's connected to a muscle, That is known as a strain. Okay, so a sprain is a ligament, strain is to a tendon. Cartilaginous injuries can happen where we have cartilage in joints, such as those menisci that we just talked about. Okay, those menisci are in the knee, and through just wear and tear, also through trauma, we can get little rips and tears into those cartilaginous structures. Those rips and tears can create a flap-like structure. You can see that there in that picture. Okay. Or what can happen is little bits and pieces can actually break off and enter the joint. Okay, those need to be removed arthroscopically in order for the patient to be comfortable if it gets too uncomfortable over time. Dislocation, also known as a subluxation, is when a bone is forced out of alignment, usually is concurrent with a sprain, inflammation, with a tear of either muscles or ligaments or tendons. You can also add strain in there as well. Common dislocations are shoulders, fingers, and thumbs. They have to be what's called reduced or put back into place. And then it's more common to have it happen because that joint now and the surrounding structures such as ligaments and tendons are lax because they've been overstretched. Ligaments and tendons, because of their decreased blood supply or low blood supply, don't have a huge regenerative capacity, and once they are stretched, they tend to stay that way. Okay, inflammatory and degenerative conditions. Let's see here. I'm going to move back out to the smart board. Okay, so I'm going to talk to you about 3 types of arthritides. There's osteoarthritis, rheumatoid arthritis, and gouty. Okay, so these are just an introduction into them, so you have a general working knowledge of them. Osteoarthritis, I hope you can read this. Osteoarthritis, if not, I'm going to read it to you, is your common wear and tear. Okay, so those old sports injuries where your knee hurts, your hip hurts, your shoulder hurts, okay, these are the wear and tear injuries of osteoarthritis. It's usually localized. Okay, osteoarthritis will be that shoulder, be the knee that you hurt, the wrist that you hurt, etc. They have an inflammatory response, okay, which means when they're aggravated, because there's an injury there, we tend to draw inflammation to that area. We can have a wearing down of the cartilage that's lining that joint. That wearing down of cartilage can expose parts of the bones which cause discomfort, and you get what's called a bone-on-bone presentation on X-ray. Okay? Because the cartilage is gone, it looks like the bone is actually touching the surrounding bone. There can also be what are called osteophytes or bone spurs. Okay, bone spur is a common term for osteophyte, which will be a projection of bone that's deposited in that area. It's the body's response to instability. Rheumatoid arthritis is totally different. This is autoimmune, okay? So this person's body, for some reason, does not recognize its joints as their own. What they do is they start to attack their own joints, okay? They get a systemic inflammation, inflammatory response, okay? It tends to affect the fingers and the neck first. It can affect any joint, though, over time, okay? One of the pathognomonic signs of rheumatoid arthritis is ulnar deviation of the fingers. What that means is instead of their fingers being straight up and down, they tilt towards the ulna. Ulnar deviation, so their fingers would all be tilted towards their ulna. Okay? Gouty arthritis. People who have gout are prone to gouty arthritis. And what gouty arthritis is a problem with the ability to get rid of uric acid. Uric acid is going to be a byproduct of protein metabolism. Okay? People who have gout have a problem getting rid of that uric acid. Okay? That uric acid builds up in the bloodstream, and it likes to deposit into joints, especially joints that are cooler, so joints that'll be further away from the center of the body. Big toe is a very, very common area for people to have this reaction in, okay? So these uric acid substances get into the joints, they build up what are called uric acid crystals, and that patient gets a lot of discomfort in that joint. Now, over time, those crystals can actually start to wear away at that joint and cause what's called gouty arthritis in the joints. Okay, I believe that's it for today's lecture. The next time that I lecture, I'm going to be lecturing about muscle. Please read ahead about muscle. Okay, one of the things I really want you to review is an action potential. I'll be going over that next week because an action potential is going to be how a muscle electrically works. We did that in P1. Please review that so you have a little bit of jump on the lecture for next week. Thank you and have a great week.